as you know, there's this Destiny Breast 01 study that was published in the New England Journal of Medicine looking at the role of one of the ADCs, which essentially is trastuzumab deruxtecan, and highly active agent. And this was in patients who failed prior HER2 targeted therapies. The one thing about this study is that they've actually found a high rate of interstitial lung disease. In fact, it was reported to be about 13% on that study. And there were about 4 patients who actually died from this complication. So that's about 2% of patients. Again, it's not common, but nonetheless, overall, it's actually not necessarily rare. 2% is relatively uncommon, but not rare for the death rate. But 13% rate of ILD is actually quite significant in terms of the high. The good news is that other than the 4 patients who unfortunately died, there were 7 patients who actually completely recovered, and 2 more that were recovering. 10 out of the patients who actually overall had the toxicity, continued to have the interstitial lung disease. So it's somewhat reversible for about half of the patients, and for the other half, it's either chronic or, unfortunately, for some, it can lead to death. Our experience in GI cancers overall is about the same. There's this study that's going to be presented actually at ASCO that looked at the same agent, which suggested again a high level of activity, so very promising level of activity with a high response rate, close to 50%, a little bit less, but close to 50%. But we've seen about 9% of patients who actually had toxicities that led to drug discontinuation. Now, thankfully, and this was a smaller study, there were only about 6% of patients who had interstitial lung disease. So about half the rate that was reported for breast, and we see about the same with gastric cancer as well. Another study. And these toxicities were either grade 2 for a couple of them, and one grade 3, and there actually were 2 drug-related deaths. So we see it in the same context. We see it at a lower rate, at least from this small study. And I'm not sure whether, and again, one has to look a little bit further into the data. With breast cancer, you get some level of radiation to the chest area. In colorectal cancer, you don't. Whether that can contribute somewhat to the elevated toxicities or not is, of course, unknown. But I think overall, it's fair to say that, from the experience we know from breast and what we see from the GI studies, the rate is about 6 to 12% of patients. So on average, about 10%, 1 out of 10 patients may develop interstitial lung disease. And consistently across all these studies, 1 to 2% of patients will actually die from interstitial lung disease. And that would be a fair assessment. The management is very similar, whether it's breast, lung, or colorectal or gastric, since the insult is not dependent on the site of the cancer, but it's related to the drug itself and its lung injury, potential. And so the management is about the same. You just continue the drug. For some patients, you will need to start steroids, and then for many patients, you may need to supplement the oxygen. At this point of time, we don't have a good idea about who is at that greatest risk for interstitial lung disease. So we don't have a way to figure that out. I must say that at least from TKIs, from what we know from tyrosine kinase inhibitors and PD-1 inhibitors, that there may be an increased risk in Asian populations for whatever reason, versus populations, Western populations. There's also perhaps some elevated risk in smokers or patients with lung disease. But my suspicion is that those patients will be more symptomatic and thus will present, with a more firm way than those that may not have lung disease or lung involvement. So I'm thinking about my colleagues from the lung cancer world, where the picture will probably get worse. So the grade of toxicity will be higher because of the level of lung dysfunction or lung damage related to smoking or cancer that's involving the lungs. But overall, again, we don't know who is that patient at greatest risk. And so more research needs to be done, and what would be the most effective method to mitigate that toxic effect at this point of time is unknown. Other than close observation, I mean, you have to do the usual. We see our patients, I mean, we take their vital signs, we include the respiratory rate, all practices. We'll check an oxygen saturation for the patients before starting any treatment period. I mean, that's part of the vitals. That's the fifth vital. So if you see drops in oxygenation, that should raise a red flag, especially with those agents. If you essentially, you have a patient with a cough, in our world, say colon cancer or pancreas cancer, and the patient has not does not have lung disease or lung metastases, that should raise a red flag. A dry cough, typically, that's unrelenting. Dyspnea, so dry cough, should elicit those folks to get a chest X-ray and then scanning if there's any question mark. Other than that, frankly, there's not much you could do. I mean, we scan those patients on a routine basis. We see them on a routine basis, and that's the closest follow-up you can afford them. And of course, anytime there's a red flag, like I said, signs and symptoms of this adverse event like dyspnea and cough, you should have a faster trigger finger to actually check a scan. An X-ray, a chest X-ray, and then a scan if needed.